Hello, I am Alejandro Jimenez-Genchi from the National Institute of Psychiatry, Ramón de la Fuente in Mexico City. In this session, I will talk about the reciprocal impact between major depressive disorder and insomnia disorder. Since ancient times, it is known there is an association between insomnia and major depression. One of the documents of the Corpus Hippocraticum contains a description of the presence of insomnia in what now we know as major depression. One can read in that document aversion to food, desperation, sleeplessness, and irritability, fear and sadness, which persists, are melancholy. Nowadays, we know melancholy as major depressive disorder. And one of the symptoms of these disorders is insomnia. So what is known from ancient times, it is present in actual systems of classification in psychiatry. However, this association had received scarce or non-attention. Just recently, and maybe this is one of the first studies which focus in the association between sleep and psychiatric disorders, particularly insomnia and hypersomnia in association with psychiatric disorders. And this figure shows how insomnia is commonly, frequently present in association with mood disorders, anxiety disorders, substance disorders, and almost any psychiatric disorders. In fact, more than 40% of patients with psychiatric disorders have a comorbidity with insomnia. It is less frequent that the psychiatric disorders occurs without sleep problems. And more recently, we know about the more detailed association between insomnia and major depression. And this study of Dr. O'Hayon and Dr. Rowe shows how do they coexist. But insomnia used to present first than other symptoms of depression. Almost 50% of patients have insomnia as a first symptom before other symptoms of depression. Either we talk or a first episode, or it is a recurrent episode. It is, as you can see in this figure, it is more frequent that insomnia presents before other symptoms, that at the same time or even after the appearance of other depressing symptoms. However, insomnia, as you can see, is present. It is coexistent with other symptoms of major depressive disorders. And And not only is the first symptom or occurs before other depressive symptoms, also can persist even after a successful antidepressant treatment. And again, in this figure, we can see how after a successful antidepressant treatment with fluoxetine, patients, in this case, all patients had a score of 7 or less in Hamilton rating scale of depression. That is to say, they were in remission. They still have residual symptoms. Some residual symptoms have enough intensity or enough clinical impact, so they are considered a threshold or subthreshold if they are not enough intense or severe. But what I want to underline in this figure is that sleep abnormalities are among the most frequent residual symptoms after treatment of depression. As you can see in this figure, almost 50%, 45% maybe, have residual symptoms in the area of sleep. And again, I want to underline that they are patients who were treated for depression and they are in remission. So insomnia seems to be one of the first symptoms, is present at the same time with other symptoms, but persist after treatment. Okay, insomnia improves with the treatment of depression, particularly antidepressant treatment, drug treatment in this case. And in this slide, you can see the changes in the Pittsburgh Sleep Quality Index, a frequent instrument used to assess sleep quality. The changes in the sleep quality after almost 8 years, 8 months of treatment with nortriptyline, and as I said a few minutes ago, sleep improves, insomnia improves, sleep quality is better after treatment, but it's not normal sleep. As you can see in the graphic, patients in this study still have a sleep quality that is not normal. It's not in the Pittsburgh Sleep Quality Index, a score lower than 5 is the indication of good sleep, such as controlled subjects. So a successful treatment may not normalize sleep, but this is something that not only happens with antidepressant drugs, also with behavioral, cognitive behavioral therapy for depression. Again, depression improves, depressive symptoms improve with cognitive behavioral therapy, with antidepressant drugs. Sleep may improve, However, sleep does not normalize. A high percentage of patients with major depressive disorders still are presenting sleep problems, insomnia complaints after treatment. Again, as you can see in this figure, insomnia complaints are present after psychotherapeutic or drug treatment in almost one half of them. So, in addition, insomnia, we have seen maybe the first or among the first symptoms is present at the same time with other symptoms, persist after treatment, but also can be a side effect of some antidepressant drugs, particularly those with an effect on norepinephrine, such as desvenlafaxine, bupropion, for example. Now it's well known that insomnia is a risk factor for depression. There are a good number of studies, prospective studies, which have found that patients with persistent insomnia have an elevated risk of development of a major depressive disorder. In fact, it is estimated that patients with insomnia have a odds ratio of 2 for developing a new episode of depression or a recurrent episode. In this way, we can say that coexistence of insomnia with major depression is highly frequent. In fact, coexistence of insomnia with another medical or psychiatric disorder is the rule rather than the exception. Almost 50% of patients presents anxiety or depression inconsistent with the sleep problem. All this information, and for sure, many other studies have led us to two distinct and independent disorders in actual editions of systems of classification of psychiatry disorders. We have major depressive disorder, and now we have insomnia disorder. This is particularly important because now we can study in separate, but also we can focus their coexistence and their contribution or the impact between one and another. So in the next slides, I will show some of the findings we have had in our center. And I please accept my apology for the Spanish in this table. But one of the first studies we conducted was a clinical evaluation of patients with a major depressive disorder, with the aim to document the characteristics of their sleep. And one of the things which was relevant in these studies was obviously the presence of insomnia, problems with sleep onset, with problems with maintenance of sleep, early morning awakenings, but also the presence of maladaptive behaviors. In fact, almost all patients with a major depressive disorder seems to have a sleep problem, more frequently insomnia. In the study we conducted, 93% of these patients had insomnia of any kind. In the study of Dr. Ohayon with a representative population of USAs, a high percentage, almost 75%, have difficulties with sleep onset. So insomnia is very frequent in patients with major depression. As I showed you in the previous slide, we found that patients with major depression have maladaptive behaviors in relation to sleep. So we conducted a study to test the cognitive model of insomnia in patients with major depression. We used different instruments: the quick inventory of depressive symptomatology, the insomnia severity index, the sleep associated monitoring index, and dysfunctional beliefs and attitudes about sleep scale, and the Penn State Worry Questionnaire. We were trying to test the cognitive model of insomnia in patients with major depression with comorbid insomnia. And what we found was that the severity of depressive symptoms was not associated, was not related with directly with insomnia. In fact, depressive severity was significantly related with worries, and worries were related with insomnia. So, and as you can see in this figure, insomnia is the center of the problem, and is through the significant relation with worries that insomnia seems to relate with depressive severity. But there is no relation between insomnia severity and depressive symptom severity. Some other elements of the cognitive model are reproduced as it happens in insomnia disorder. What I mean, insomnia was significantly associated with worries, with sleep-associated monitoring, with sleep-related behaviors, and dysfunctional beliefs about sleep. So it was a surprise to find that the severity of depression was not associated with insomnia severity. In this other study, we compare the practice of sleep hygiene and also sleep quality and insomnia severity among patients with insomnia disorder, insomnia comorbid with major depression, and good sleepers. You can say some of the characteristics of the sample and some of the instruments we use. And what I want to show you is that patients with major depressive disorders have higher scores on insomnia severity. They also show a worse sleep quality, and they also showed the worst practice of sleep hygiene. The practice was the worst, even worse than patients with primary insomnia. We were also interested in assess the different components of sleep hygiene in this sample and identify if there was a relationship between the practice of sleep hygiene and the sleep quality and insomnia. And as you can see in this table, is that sleep hygiene in the case of patients with primary insomnia was significantly associated with the practice with the sleep quality, particularly arousal-related behaviors. However, in patients with major depressive disorder, there was no relation between the practice of sleep hygiene and and insomnia, and there was no relation between sleep hygiene and sleep quality. The only element and we found a low correlation coefficient was between arousal-related behaviors and sleep quality. So sleep hygiene, while in patients with primary insomnia, seem to show a relation with sleep quality and with insomnia, in patients with major depressive disorders, does not seem to be related, even when this group has the worst practice of sleep hygiene. After these results, we focus on pre-sleep arousal activity, again in patients with insomnia, patients with major depression comorbid with insomnia, in comparison to good sleepers. What we found is that patients with major depressive disorder have the higher scores in both somatic pre-sleep activity and cognitive pre-sleep activity, higher than the patients with primary insomnia or insomnia disorder, as we know nowadays, and also good sleepers. So this group of patients with with major depression comorbid with insomnia disorder seems to have the worst insomnia. And they seem to be different from patients with insomnia disorder with no comorbidity. In another study, which was presented in a sleep meeting, we assessed the the changes in insomnia severity when CBTI was added to treatment, this in comparison with usual treatment in outpatients with major depression disorder with comorbid with insomnia. What we found was that insomnia insomnia scores had a decrease, but also symptoms of depression improved. Although this was not a significant change, they show a decrease with CBTI. This study, these results have been reproduced, and now we know that CBTI for insomnia is a good option in patients with major depression with comorbid with insomnia disorder. And finally, we have been studying objective sleep and neuropsychological performance in patients with major depression comorbid with insomnia. And in preliminary findings show that with respect to subjective measures, insomnia severity was significantly associated with working memory. And in contrast, the depression severity, the severity of depressive symptoms did not show significant association with any cognitive variable. So insomnia is showing association with working memory, but depressive symptoms do not seem to relate with neuropsychological performance. And in relation with objective measures, only total sleep time was associated with episodic memory, specifically word list and memory cues, and sustained and split attention, measured by the D2 test. No other sleep stages or parameter of PSG was associated with neuropsychological performance, but total sleep time was significantly associated. This is particularly important if we consider the phenotypes of insomnia which have been recently proposed. Those with short duration, less than 6 hours, or those with normal duration who sleep more than 6 hours. So, sleep duration of sleep in patients with insomnia disorder comorbid with major depression seems to be a group which is needed of research. So, as conclusions, we can say that insomnia and major depression have a close and complex relationship. There are many elements we have to focus and study, and in particularly in this case, the case of major depression comorbid with insomnia, there are many questions, and they are needed of answers, because major depression comorbid with insomnia is probably the more frequent expression of these disorders. The comorbidity is highly frequently in clinical settings. And among those questions are, do they simply run in parallel? Major depression, insomnia disorder, or they are interacting. And how do they interact? Thanks for your attention. I also want to thank Dr. Ohayon for this opportunity to participate in this symposium. Thanks.